show you again and about treatment at the time of resistance to TKI non-small cell lung cancer. So, and trust me, I will make it very interesting. I will make it very short because more than you, I am more inclined to go and have the backwaters. So, bear me with for 10-12 more minutes and I will make it short and sweet for you. So, my first reactions when I saw this topic about treatment at the time of resistance was this. This is Benjamin Solomon presenting the crown data. This is Suresh Ramalingam presenting the flora data. And I said, why this collaboration? This is Indian cricket team winning the T20 World Cup. So I said, yeah, when we are doing so good, why this collaborating? Why do we even have to, talk about at the time of resistance? My subsequent reactions to this was, immediately after we won the T20 World Cup, Kohli retired, Rohit Sharma retired and Jadeja retired. So there is a time and place. Everybody comes to shelf life. Everybody will stop working after a particular time. Not if you are Govind Babu sir, you will work till eternity. You will work for you're not working only. Fantastic. So you need to have a plan B always over there. Okay. So let's just look at the PFS curves of first and second, third generation TKIs. There can be primary resistance. 20% of people will not respond to them. And even if they respond, the PFS of the first generation TKI is only 10 months. In case of third generation TKIs, the PFS is only 18.9 months. That basically means that after 19 months, you will require to have a plan B, and that is very, very important. So, welcome to reality. Like we came and saw, we don't trust our pathologists, we don't trust, we have only this thing. We need to understand that not everybody will respond to the treatment for time immemorial. Now there are three distinct types of pattern progression when you have a resistance. You could have a systemic progression, you can have a oligo progression, you can have a CNS sanctuary site. So number one, if you have an oligo progression, you do not need to change the treatment. If you have a systemic progression in the brain, you do not need to change the treatment. You just need to put some local therapies. In fact, the surgical colleagues in our departments have become very vociferous. And when it comes to systemic PD, it's more often than not now surgery which is actually calling the shots. So, tip number one, not all progressions are created equal. Just a pathological report, metabolic active disease with 2 lymph nodes in the lung, please don't listen to that. Now, what happens if you give radiotherapy to the progressive side in EGFR mutant non-small cell lung cancer? Contrary to what all the radiation oncologists believe, you are not going to cure the patient over there. Very importantly, if you have a progression on either a osimertinib or a gefitinib, the median PFS2 is not more than 4 to 5 months. But 4 to 5 months is reasonably okay. It's a median. Some people may do more, some people may do less also. Can you continue EGFR TKIs? Medical oncologists, patients, you don't want to let go of the drug which is acting. Again, if you see, the median PFS over there is not more than 3 to 4 months. So once you have a progression, keep your plan B ready, talk to the patient, tell them, listen, it is good when it lasted, but you may have to change the treatment. You can use radiation, you can continue TKIs if the patient is asymptomatic, you can use surgery, but ultimately the progression is going to be around 3 to 4 months. You need to have a change of the treatment. So tip number 2 here is that there are modest improvements with the use of local ablative therapies or treatment beyond progression of 3 to 4 months. Now, this is my crux of the slide. Why does resistance occur? The acquired resistance, why does it occur? You can have this something called as an on-target mutation. You can have something called as off-target mutation. You can have something called as a change of the phenotypic this thing. This looks a very busy slide, so I'll make it very interesting for you. We all have seen this photograph. This is a predominantly South Indian this thing, so I don't know. This is Shah Rukh Khan's very important picture called as Kuch Kuch Hota Hai. This is his girlfriend, this is his potential wife. So, if the mutation occurs over here, you are in relation with the girl, you look at someone else. That's an off-target mutation. So, if you have EGFR, you develop a MET or an ALK. Ma'am, this is the way I learned my oncology, what to do. My wife doesn't know this. So, this is an off-target mutation. If you have a problem with your girlfriend or wife only, which is most common, that is basically an on-target mutation. But if you change your psychology only, Shah Rukh Khan from a chocolate boy becomes a villain, that is a phenotypic transformation, that is just start. On target, off. Dr. Govinda was remembering something. I am not answering that, sir. So you have on target, you have off target, you have phenotypic transformation. So let's look at what on target. So let's go to the girlfriend or wife or a spouse or a husband where you have a problem. If you develop a mutation in the first generation TKIs, if you have given gefitinib or erlotinib to somebody and you get a mutation, in those cases 60% of people will have a T790M. T790M mutation basically is that where your threonine gets substituted from methionine and you have a drug called as osimertinib. Now osimertinib will only act if you have a T790M mutation positive. If you don't have a T790M mutation positive, it will not really act. Now, can you improve upon osimertinib? The PFS over here is only 10.2 months versus 6.4 months. But as medical oncologists, we always say dil maange more. We always want to have more. So, can we combine anti-angiogenics to osimertinib? It was tried where second generation osimertinib was added to anti-angiogenic to osimertinib. It basically the result came as 0. It doesn't really work. So OC plus Bev versus only OC, it doesn't act. Now this is something which is very important. This is something which a molecular pathologist will ask us to do. So what they did was, somebody will develop a T790M. Normally what we do is, you do a T790M mutation at the time of progression. What they did was, they did T790M every 3 months. And the moment the molecular report basically came positive, they changed the treatment. So a molecular relapse will occur earlier than a clinical relapse. And what they basically found out was that if you treat at the time of molecular progression only without clinical progression, you may get a similar curve to osimertinib. In a past country like us, we can do that. But again, very small study, only 8 patients had basically this thing. But if you treat them, test them, do a ddPCR for T790M every 3 months, this may also be an option. Now, what about resistance to osimertinib? You have given gefitinib or erlotinib, PD, osimertinib. Now, what about resistance to osimertinib? This is almost what I call as आसमान से गिरा खजूर में अटका. Now, you have a T790M mutation. You may develop a C797S mutation also. Again, very important. This does get asked to us a lot in the WhatsApp groups. If you have a T790M mutation positive, look at the 797 mutation. If it is in cis or it is in trans. If it is in trans, you can go ahead and give OC plus gefitinib. If it is in cis, you do not do anything. Go ahead with the 4th generation TKI or something else. So this is very important. Ask your molecular pathologist, do a molecular tumor board, ask whether this is cis or trans. That is very important actually. So, tip number 3, ask your molecular pathologist about whether there is a C797S mutation or not. What about the good old chemotherapy? That is what everybody will probably give. Again, chemotherapy has a response rate of 30 to 40%, median PFS of around 5 to 6 months, and that is what basically is. But do not forget chemotherapy. Chemotherapy is always there. Now let's look at if you give osimertinib in the first line. This was first, second generation. Now please remember, osimertinib in first line is not equal to osimertinib in second line. Anything which is given in second line is not that great. If you have osimertinib in the second line, you have more acquired amplifications and you have more met amplifications. So tip number 4 is, if you are looking for mutations or resistance pathways beyond osimertinib, please don't go ahead and do a 12 gene panel. You need to do a broader based panel because the 12 gene panel will not cover for amplifications. So again, order the NGS test that you actually want. That is very important. So again, please remember कुछ होता है. You have 4 ways. You can have on target mutations, you can have off target mutations, you can have phenotypic transformation. So in case of osimertinib, you have an on target mutation. You can have other trials. You have 4th generation EGFR TKI. You have 4th generation EGFR TKI also coming up. The only problem is the way they are going to name them up is going to be very difficult. They should keep them very simple name. I don't know how it will really happen. So the bypass inhibition. Most importantly, what is very important is if you have a person on osimertinib, look for MET amplification. Always ask your molecular pathologist that did you check for MET amplification. And if you get MET amplification, you can actually try a third EGFR TKI plus MET inhibition. only crizotinib, only capmatinib, only tepotinib will not work over here. If you have to give, you have to continue your osimertinib plus add something. So there are many studies, Orchard, Savannah, Insight, again a response rate around 41-42%, but the drug is very well tolerable. That is there. We were a part of the Savannah program and we did participate. There was one patient who lasted for around 12 to 18 months on this combination, which is doing absolutely okay right now. So always look for MET amplification if you are going to do a resistance pathway post osimertinib. So osimertinib and MET inhibitors, they work with modest improvement in PFS. Now we have spoken about this. There is something called as amivantamab. Now that is the Mariposa trial. Again, Mariposa trial was there, which compared amivantamab plus chemotherapy. It also led to an improvement in PFS, but there is no improvement in OS till now. Second thing is, if you are going to give amivantamab, please be very good friends with the dermatologist, because people will get diarrhea, they will get skin lesions, they get paronychia, they get lot of lesions over here. But it's got an improvement in PFS over here. You can go ahead and give them ADCs, you can give them sacituzumab, you can give them datopotamab, you can give patritumab deruxtecan. We have a clinical trial coming up. Not only we, a lot of people have got clinical trial coming up for this. Look out for the trials and people can get involved in that also. What about immune checkpoint inhibitors? This is the most burning issue. You know, I saw in her presentation, a lot of people, I mean, when you go to Kokila, everybody gets immunotherapy. Nobody doesn't get immunotherapy. You know, I mean, you know, when I tell them, what is it? हाँ sir, वो immunotherapy दिया था. Now, important, I had to make this joke. Okay, immunotherapy post EGFR osimertinib single agent does not work. Now, let us be very honest. Even if your PDL1 is 90%, it will not work. But if you combine immunotherapy with an anti-angiogenic and chemotherapy, that is because the TME what madam showed over there is different. It's an immunosuppressive thing. But if you add atezolizumab to bevacizumab, it does act. There is no role of IO alone post EGFR resistance, but atezo and bev. The only place where atezo and bev has a role is if you have PD on an EGFR TKI actually, again with a modest PFS of around 10 to 12 months and OS around 9 to 20 months. Now this is very important. This is what Dr. Amit showed in her lecture. People can develop small cell transformation, people can develop squamous cell transformation. Now how do you really know which patients will develop? In your NGS report, and that is why people said about 12 gene assay, yes, but 12 gene assay will not look for RB1 mutation, they will not look for TP53 mutation. If you have a triple mutation, that is if you have an EGFR, RB, P53, please go ahead and do a biopsy for them at the time of progression, because there is a 40% chance that they will go ahead and develop a small cell transformation. Once they develop a small cell transformation, please don't go ahead and add immunotherapy. There are clinical trials going on, but it doesn't really work. I mean, our standard etoposide carboplatin is absolutely okay. So, a EGFR mutant transformed small cell lung cancer is not similar to a de novo small cell lung cancer. A de novo small cell lung cancer has got smoking, high TMB, everything. Our EGFR transformed NSCLC doesn't really have that. So that is also very important. But please look for RB mutation, P53 mutation and EGFR. The triple mutation, you have a chance it will go and turn up into a small cell. People do get transformed into squamous cell transformation, so we do rebiopsy them very importantly, and these people are then treated with Paclitaxel carbos and not PEM carbos actually. This was about EGFR. I'll spend 2-3 minutes about ALK. Again, when you talk about resistance to ALK TKIs, think about whether you are giving first or second generation, you are giving third generation. Why I tell you is important is because in first and second generation, you have a mutation called as G1202R. Now, if you have a G1202R mutation, please do not give them electronic or serotonin. It is not going to work. The only thing which is going to work is lorlatinib in first, second generation. That is also very important. This was a trial of lorlatinib which basically compared lorlatinib after first TKI, second TKI and everything. And again, you basically found out that if you give it after first generation TKI, the median PFS is only 11.1. If you go ahead and give them after second and third generation, the median PFS is around 5 to 6 months. So, Again, tip over here is lorlatinib in second line is not similar to lorlatinib in the first line. Lorlatinib in second line is a much inferior drug than out over there. If you have given lorlatinib in first line, then what happens? Do not bother looking for ALK mutations, it doesn't come. Go ahead and look for amplification pathways, look for MET, look for EGFR and stuff like that. And that is important. Very important in Crown trial, what they did was, after lorlatinib, they gave them alectinib, crizotinib, ceritinib, brigatinib, and the median PFS actually over there was 9.6 months. So I don't know what is happening, but after lorlatinib, you can definitely go ahead and give them ceritinib and alectinib and stuff like that, which will basically happen. What about immunotherapy in ALK non-small cell lung cancer? The answer over here is, look at this graph. No objective responses, no objective responses. It does not really work over here. So there is no role for immunotherapy alone or in combination with an ALK non-small cell lung cancer. Immunotherapy in ALK non-small cell lung cancer is no, nada, nilch, nothing will work over here. So to end my conclusions, not all progressive disease requires a change of treatment. If it's an oligoprogression, if it's a progression of the brain, give RT. On target, off target mechanisms are very, very important. Please possible do a biopsy to rule out histological transformation. Send for NGS. Do not send for a 12 gene panel NGS. Send for a broad based panel NGS. Immunotherapy alone has got no role. Immunotherapy combinations have got a role in the management of EGFR mutant non-small cell lung cancer. In ALK, doesn't really work. Clinical trials are coming up for optimal management of these patients. Always be on the lookout for clinical trials, and that to me is a very, very huge importance of plan B. With this, thank you. My plan B is there in the afternoon, 2 to 6, a houseboat. If you have a plan B over here, let me know. Thank you. I have a plan.
Thank you, sir, for the interesting session. The session is now open for discussion.
Sir.
EGFR patients, sequential therapy is better or third generation?
So third generation TKIs is anything better because 30% of people after EGFR TKIs do not take second line treatment. Plus at the beginning, we don't know whether the patient will got a T790 or not.
But the results say that sequential therapy overall survival is better.
If they get a T790 mutation. Now when I am starting a patient and T7 on a EGFR TKI, I don't know whether they will get a EGFR T790 or not. That's the problem. So if a person can afford, definitely you should go ahead with third generation TKI to start with. The toxicity profile, the brain penetration, everything is absolutely okay. So if a patient can afford, that is the most important.
One second. In your practice, patients having a good response, symptomatic, when do you reassess again?
So we reassess initially in the first year after around every 4 to 5 months, second year 6 months, third year 6 months once, and I always do an MRI brain. Forget the PET scan or a CT scan, I always do an MRI brain. Because in our database, 38% of people have got asymptomatic or symptomatic brain mets at presentation. Small nodules here and there they will get. So yes, I do always that.
So you also concisely told us how we treat lung cancers in progression. I just wanted to add one point. Like there is a state called induced oligometastatic state. That is the state is what I feel is the time you stable and not when it is progression.
I totally agree. So with oligos, there are 9 types of oligos. You have oligo persistence, you have oligo progression, you have oligo resistance, you have oligo de novo metastatic. So in our tumor board, we do a lot of discussions about this. So if a patient has been doing very, very good and has only an oligo persistent cell, but that depends upon when. Whether you do it at 6 months, 12 months, 18 months, 24 months. Typically, I do it after the median PFS of the drug has elapsed. So somewhere around OC model for 12 to 18 months, I'll send it to my radiation oncology colleagues, ask them to give radiation over there. I totally agree with you. No data conclusive, but absolutely no.
Data working towards it.
Yes,
So
yes.
persistent and induced oligometastatic.
Correct. So I agree with you. We should be doing to increase the PFS over here. Totally agree.
So you said there is no role of IO in
IO alone or in combination in ALK?
That is in first line, right? Not in
Second line also the data is very even in the IL power trial I will show you that even in the IL power trial there were hardly 6 or 7 patients which were taken.
I think ABCP doesn't
only
doesn't work much in alcohol.
8 patients. It mainly was an EGFR.
But the pemetrexed based chemo in alcohol
Yes, it works very well.
with pembro.
It works very well. So yes, so there is a role of chemotherapy.
Plus pembro in alcohol.
Pembro doesn't add much. So let us say chemotherapy has a 35 to 40% advantage. Pembro adding will add 1 or 2%. It's not worth the effort actually.
I have a patient who's alcohol in
Fantastic.
So
You don't know what is working.
Carbopem pembro is almost
Yes, so you don't know what is working. This is only carbopem or carbopem and pembro which is working.
pembro maintenance.
Alright, fantastic.